This slide's presentation will provide an overview of the pathophysiology for multiple sclerosis. Multiple sclerosis was first identified in 1868. It is an autoimmune disease that primarily affects the central nervous system, and it's characterized by neural inflammation, demyelination, and gliosis. And as you can see by looking at the picture on the right-hand side of the slide, MS is one of the most common autoimmune diseases. As I said, the pathophysiology, what you see in the picture in the right-hand side of the slide is a healthy neuron compared to a neuron that has been affected by multiple sclerosis. You can see that the myelin, if you remember the oligodendrocytes, produce the myelin that wraps the axon of the nerve. In patients with multiple sclerosis, this myelin is damaged and results in exposed nerve fiber. Myelin can be destroyed in the brain, the spinal cord. If it's damaged in the spinal cord, it's known as transverse myelitis. It could be in the brainstem or any of the cranial nerves, knowing that cranial nerves are part of the peripheral nervous system, but they are affected by multiple sclerosis. Particularly the optic nerve is the most common. Once the axon becomes damaged, this damage is irreversible. So the myelin has the opportunity to grow back occasionally. However, when it doesn't and the axon is damaged, it doesn't heal. This results in neural scarring, hence the word sclerosis. As far as patients with multiple sclerosis are concerned, about 90% are diagnosed between the ages of 16 and 60. You should know that MS can develop earlier than this or later than 60 years of age. Women are 3 times more likely to be diagnosed with MS, but if a male is diagnosed, they appear to have a more aggressive form of the disease. Caucasians in general are more likely to be diagnosed with MS compared to Hispanics or African Americans, and MS is very rare in Asians. It's also prevalent in temperate zones. That means zones that are further away from the equator, and about 500,000 people are diagnosed with MS in the United States and Canada, with about 2.1 million worldwide. To acquire MS, there appears to be some sort of genetic link, since if you have a first-degree relative with MS, you have a 3 to 5% greater risk of developing MS. It's also been shown that twins, if one twin has MS, then the other twin has a 20 to 39% greater risk of developing MS during their lifetime. And as I said, there seems to be a correlation with the distance from the equator. It appears that individuals who live further away from the equator are more apt to acquire MS in their lifespan. Some people have said that this might be related to a vitamin D deficiency. Deficiency and smoking can increase the risk of acquiring multiple sclerosis. Okay, the equator phenomenon is depicted in the right-hand side of the slide, with the darker color being those individuals who are at greater risk for developing MS. And you can see that there's a lot of people who are living in the temperate zone who are more apt to develop MS. Another risk factor is going to be tobacco exposure. Some individuals have linked diet as well as body weight or obesity, and the Epstein-Barr virus infection appears to predispose someone to developing MS during their lifetime. This slide shows some of the common symptoms associated with MS. However, you should be aware of the fact that not everybody gets all of these symptoms. All the symptoms are going to vary from person to person, and they're going to vary over time. So as far as central issues, you can develop fatigue. There can be cognitive impairment, depression, unstable mood. You might have some visual issues with nystagmus developing or double vision, going to have difficulty seeing. Things are going to be blurry or double. The patient might develop dysarthria, trouble swallowing, weakness, muscle spasms, ataxia, definitely spasticity. They might have pain or numbness and tingling or paresthesias in any part of their body. They might develop incontinence of bowel or bladder, or they may also experience urinary retention. And one of the problems with the MS is that since not everyone develops the same symptoms at the same time, it's difficult to diagnose. We'll talk about that a little bit later. The other big problem is that a lot of these symptoms are just that, symptoms. They're not really signs. They're very evident to the person. So, for example, they might be more tired, or they might be feeling weak, or they might have pins and needles in their hand, which are often an initial symptom, but that doesn't really mean anything. It doesn't really associate with everything because, I mean, everybody gets tired every once in a while, but this is a different kind of fatigue. Initial presentation, it's often transient. It kind of comes and goes, and it's usually very mild and goes away on its own. It's only after being diagnosed with MS officially that person can look back and recognize the fact that this was their first sign of MS. They might have, as shown here, again, talked about this before, they might have difficulty thinking, or they're tired, and then suddenly their vision is messed up. They can't really see clearly. They might have double vision. They might be tripping for no reason, falling over the floor. And they might have the strange skin sensations, or the pins and needles, or the paresthesias, but nothing major, right? These are mild, and they kind of go away in a little while. As I mentioned previously, it's difficult to diagnose this problem since patients present with a variety of different symptoms that are also ambiguous. This slide shows criteria that were developed starting in 1996, and they keep updating these criteria for diagnosing MS, and they're known as McDonald's criteria. By McDonald's criteria, you need at least 2 clinical attacks. That means demonstration of symptoms that are related to MS symptoms that last for at least 24 hours, at least 2 times. And you also need to have a T2-weighted MRI that shows evidence of dissemination in space. That means the lesions that are visible on the MRI have to occupy unique positions in the central nervous system. Or dissemination in time, which means at least 2 different time periods. Additionally, you can also have elevated IgG levels in your CSF, or cerebrospinal fluid. To kind of put this all together, check out the table from the paper that's referenced above for the McDonald's criteria as of 2018. Starting at the top and under clinical presentation, if you have more than 2 clinical attacks and objective evidence of greater than 2 lesions on the MRI, then you can be definitively diagnosed with MS. However, if you have greater than or equal to 2 clinical attacks and only 1 lesion visible via MRI, then in order to be diagnosed with MS, you need another lesion by MRI or another clinical attack that is differentiated in space. Now, if you have 1 clinical attack and objective evidence of greater than or equal to 2 MRI lesions, then you need a disseminated in time, or DIT, an additional attack, or via MRI, disseminated in time, or you can have the presence of the CSF-specific oligoclonal bands indicating elevated IgG levels. And then finally, if you only have 1 clinical attack and 1 evidence of lesion via MRI, then you need disseminated in space, an additional clinical attack, or another MRI lesion. Or you can have something disseminated in time, an additional time period later on, an additional clinical attack, or another lesion visible via MRI. Or if you have CSF-specific oligoclonal bands, then that would give you a definitive diagnosis for MS. Okay, lots of information. As I say, they update these every 5-10 years or so, but definitely worth noting that it is very difficult for these patients to get a diagnosis even after they've had symptoms. Okay, as far as prognosis is concerned, there are some factors that seem to predict a more positive course for MS, and that would be onset with only one symptom. So patient has fatigue, lasts a couple of weeks, and that's it. If the onset's before the age of 35, that's better than if it's after the age of 35. Monoregional versus polyregional attacks, these are regions that are identified on MRI. So if there's just one particular brain region that's identified, then that has a better prognosis than multiple regions. As well as something called a complete recovery after an exacerbation, leaving no impairment. We'll talk a little bit more about that when we talk about kinds of MS, but all these things are predictive of a more positive prognosis. A poorer prognosis is associated with age after 35. As I said previously, being male gender, any kind of brainstem symptoms, which would include nystagmus, tremor, ataxia, dysarthria, and again, a poor recovery following any exacerbation that the patient might have. Okay, special issues for patient with MS. And the big one that you need to be aware of is the ambiguity of the disease. They can present with lots of different things at lots of different times. Also, there's an unpredictability of the disease. These symptoms can come and go, and sometimes the patient can recover completely before another onset of symptoms, or sometimes they don't recover completely and then they just stay there. Also, the covert symptoms, I've talked about this before, that all these things tend to be invisible, right? The fatigue, the pain, vision changes, bowel and bladder, numbness and tingling or paresthesias, they're something that are symptoms, invisible symptoms, not really signs. So when you're working with somebody who has MS, it's really good to be very empathetic about what they're going through and also listening to any changes or any new symptoms that they might have. As far as categories of MS, the National Multiple Sclerosis Society has defined four that we need to know about. Okay, there's the clinically isolated syndrome, relapsing remitting, secondary progressive, and primary progressive. And the chart on the bottom right of the slide sort of gives a brief overview of each of these. We're going to take each in turn as we go through the rest of the presentation. So first, clinically isolated syndrome. It's nothing more than what it sounds like. That person has to have an episode that lasts at least 24 hours. Okay, this episode is more apt to be caused by inflammation and demyelination in the central nervous system. Symptoms could be visual, could be paresthesias, numbness and tingling, could be in the face, the bodies, or the upper or lower extremities. They might have just weakness in the arms and legs on one side of the body, more affected than the other. They may also have spasticity, could possibly have fatigue. They may also present with bowel and bladder problems. However, a clinically isolated syndrome is depicted on the right-hand side of the slide, where if you have on the y-axis patient's disability with any of these things that are listed, over time, you see that there's one isolated incident, and then patient either comes back to baseline or doesn't come back to baseline and is left with some residual symptoms. This is clinically isolated syndrome. It is known that a large majority of patients who present with clinically isolated syndrome will go on to develop full-blown MS. But remember, by McDonald's criteria, if the person only has one episode, they're not yet multiple sclerosis. Okay, the next is relapsing remitting MS. Okay, this is the most common form at time of diagnosis, where approximately 85% of patients are in relapsing remitting MS when they're first diagnosed. Here, there's clearly defined attacks, with full recovery between attacks or minimal residual deficit after the recovery. The periods or the time periods between relapses or exacerbations are free of disease progression. So they either come all the way back down to normal or they maintain a little bit of disability after the attack. Okay, you can see this on the right-hand side of the slide. The y-axis is increasing disability and the x-axis is over time. And each of the bars that you see would represent an exacerbation or relapse of the patient through MS. With relapsing remitting, the majority of the time, the patient's going to come back down the baseline, but over time, they're going to experience relapses or exacerbations. You can also have the possibility, shown on the bottom, that you have a relapse or an exacerbation, but then you don't come all the way back down to normal. But then you'll have another exacerbation, and again, you have increasing disability. But the periods between the relapses are relatively free of disease progression. The next category, or I like to think of it as the next, is secondary progressive MS. The majority of people start out with relapsing remitting, but 50% of the people will develop secondary progressive MS within about 10 years. Okay, what this is it's relapsing remitting and then progression over time. And the best way to see it is if you look at the charts on the right-hand side of the slide. So increasing disability again on the y-axis, over time on the x-axis. You can see the relapsing remitting process happening on the top. So you have two exacerbations, but then you reach a point where the next exacerbation isn't an isolated relapse that comes back down to or close to baseline. It starts to take off. So that person has period of disease progression that goes for a while before they level out. And then again, they have another disease progression before they level out. Okay, this is characteristic of secondary progressive MS. Again, original relapsing remitting, followed by secondary progressive. And then there's another primary progressive multiple sclerosis, which is relatively rare. Only about 10% of the people get this. It's really just a disease progression without any plateau. No disease progression between relapses or exacerbations. It's a steady increase in the patient's disability without individual attacks. You can see on the right-hand side of the slide, increasing disability again on the Y. The x-axis is time. And whether you look at the top or the bottom, I think you get the pictures. Once they start having symptoms, they just keep getting worse and worse and worse. The disease itself, disease progression, just continues to progress without any remitting. Okay, to be considered a relapse or an exacerbation, they must be new or they could be recurrent symptoms. Okay, so if they've already had, if they're clinically isolated, they could have the same symptoms that they had before, or they could be completely new symptoms depending on which part of the CNS has been demyelinated. As I keep saying, they must last at least 24 hours and they cannot be related to another disease process. So if you look on the right-hand side of the slide, you can see patients when they polled the Multiple Sclerosis Society, they polled patients to see how long did their last relapse or exacerbation last. Approximately 20% said less than 1 week. So others said between 1 and 2 weeks. That's the most common. About 27% said that, and so more. So there are some here that at the very bottom you can see, 3 to 6 months, or the relapse lasted more than 3 to 6 months. There are some factors that are known to trigger a relapse or exacerbation. Those are listed on this slide. You can see that a general health decline, whether it be any kind of infection, disease process of a major organ system, these are all known to trigger a relapse. So any kind of change in your immune system. Also, the hard part is stress. It can be a major life stress, or it can be any kind of minor stress. All these stress things are known to affect your immune system. So if your immune system gets affected, whether it's a health decline or an infection, or whether it's just some sort of life stress, even minor stresses are known to trigger a relapse in this patient population. So really important information for patient education. There's also something called a pseudo-exacerbation. I mean, this isn't a full-blown relapse. However, it might feel like a full-blown relapse. It's known as Uthoff's symptoms, and it's really just heat intolerance. And it's a temporary worsening of the patient's symptoms caused by anything that raises body temperature. Okay, things that are known to trigger Uthoff's symptoms are shown on the right-hand side in the picture. Okay, exercising and getting hot, overdoing it, exercising in hot and humid weather, any kind of sauna, hot tub, hot showers, hot baths, recent infection, even direct sunlight can cause a pseudo-exacerbation. And these is considered a pseudo-exacerbation because the episode comes and goes quickly. It lasts for less than 24 hours. However, the patient is definitely feeling dramatically reduced function with increased fatigue. But to help with this, a common intervention is just cooling off. So you can go from a hot tub shower to a cold shower, or sitting in a cold bathtub, or using ice packs. Those are all things that can help with pseudo-exacerbations. As far as a time course for MS progression, and as I said this many times before, it's going to vary from person to person. However, early on, you should know that there's demyelination and there can be remyelination, but it's going to be variable. And the length of time that it takes for remyelination is going to be related to the recovery of function during the periods of remission. So think here, relapsing, remitting. You think about the time period where the person is having a relapse, that's going to be the axon remyelination. But as I've shown you previously, depending on the kind, early on, you might not get complete remyelination. Okay, later in the disease process, you can see that after the demyelination, then axon loss can occur. Okay, we talked about this early on. You don't have as much inflammation in the later stages, or for example, primary progressive or secondary progression, because over time, you're losing your axon. Okay, your axon's becoming damaged. At this time, in the later disease stages for MS, it becomes a neurodegeneration process, and the disease progression is going to be more constant.